After a few more people start coming in, welcome everybody. Welcome. Well, I think we're having a few technical difficulties with Dr. Hillengass, but we're going to go ahead and get started with two of the three panelists that we have here already. So hopefully Dr. Hillengass can join in as we get started. But I just wanted to say welcome to everybody to the Throwing Bones panel discussion of enhancing quality of life in cancer. There have been so many advances in the treatment of all cancers that we are entering a time when we can explore the significant impact of non-chemotherapeutic interventions on the quality of life and the immune function of patients with cancer. How can lifestyle choices impact cancer treatment, patient well-being, and what does life look like while being treated? The three experts coming from the hematological and specifically the multiple myeloma communities come at this question from different perspectives and with a slightly different focus. And so I have to stop and thank our annual sponsor, Janssen Oncology, for making this panel and our support groups this year possible. So let me go ahead and jump in and introduce our panelists so that we can get to the good stuff. Dr. Urvi Shah is a board-certified hematologist and expert with expertise in diagnosing and treating plasma cell disorders at Memorial Sloan Cancer Center. Dr. Shah's research has focused on studying the role of diet, microbiome, and other lifestyle-related risk factors in plasma cell disorders and identifying interventions to improve outcomes for these patients. She also studies immune therapies, including CAR T cell therapies for multiple myeloma. Dr. Betsy O'Donnell is the Director of Early Detection and Prevention at Dana-Farber Cancer Institute. She herself is an athlete and oncologist, so Dr. O'Donnell uses her personal and professional experience to focus on integrating lifestyle with cancer treatment and quality of life. And her work studies the effects of lifestyle medicine to improve patient outcomes, and I'm looking forward to hearing what she's and how she connects those. Dr. Hillengass, who's not here yet, is the chief of myeloma at Roswell Park Comprehensive Cancer Center in Buffalo. Dr. Hillengass has focused on non-therapeutic interventions for some time and analyzing the influence of physical activity on pain as a result of bone disease. And hopefully he'll have some updates on his 150 patient study on non-chemotherapeutic interventions. So first, we'll go ahead and jump right in. Dr. Shah, can we start with you and the role of diet in cancer treatment?
Great. It's a pleasure to be here with you all and talk about this important topic. I know most of it's going to be a discussion, but maybe I thought that I could just go over, for those of you who are not familiar with some of the slides from our pilot nutrition study and how it has helped some patients improve quality of life and why this is important to discuss. So I think you can see my slides.
Yep, looks great.
Great. So when we think about quality of life and dietary patterns, we do know a lot about just dietary patterns and cancer risk, especially myeloma risk, that's available to date from large population studies. So there's one looking at the EPIC Oxford study. This was many years ago. You can see almost 10 years ago, and they divided patients into boxes of vegans, vegetarians, meat eaters, and showed a reduced risk for those who were eating more of a vegan, vegetarian dietary pattern. But the issue with this study is it's a small study. There are only 65 myeloma cases in the study. Another study, which was more recent, looked at different dietary patterns, and what they showed is, and this was bigger, more cases, 478 myeloma cases, that high inflammation dietary pattern is associated with a 16% increased risk of myeloma in men. More recently, we looked at diet in the NIH ARP data set, and this was the largest to date with over 1,300 myeloma cases. And we classified patients with looking at a plant-based diet index. So a higher score means more of healthy plant foods, and a lower score means less. So it's more like on dividing patients into quartiles of 4 groups. So the highest group compared to the lowest group had about a 17% reduced risk of developing myeloma. We also looked at the precancerous state, the MGUS, and we looked at a case control study, so diet versus cases with MGUS versus controls who don't have MGUS, who had been tested for MGUS. And we see that cola, soft drinks, sugary drinks were associated with a 30 to 60% increased risk, whereas whole grains, fruits, and vegetables with a reduced risk. We also do know from multiple studies, and I'm showing you two of them here, that patients that have an elevated BMI are twice as likely. So this hazard ratio of 1.98 means it's double the risk for someone who has normal weight compared to an elevated BMI in terms of risk of progression to myeloma from the precursor MGUS. And we see the same thing with this other study from the Mayo Clinic, which also is about 2, so double the risk for an elevated BMI. Knowing what we do know, we decided to look at a high fiber plant-based diet where we provided patients with a food for 3 months and coaching for 6 months and followed patients for a year on this study. And patients with MGUS smoldering myeloma and an elevated BMI were included. Overall, only 3 patients dropped out during these 3 months, and 2 of them dropped out due to medical reasons other than related to the study. And only 1 dropped out due to non-compliance or adherence to the dietary intervention. So overall, patients were able to actually follow it. And then results from the study, we did look at dietary adherence. So what are the percentage of unprocessed plant food intake before the study, which was about 20%, and it increased to 90% on the study. And even 1 year out from the study, it was about 60 to 70%, so much higher than when they started the study. We also see that the weight improved, even though they were eating to satiety with no calorie restriction. There was a reduction in calorie intake because they were eating more fiber-rich foods, and about an 8 to 9% reduction in the BMI on average was seen, and this was actually maintained a year out too. This is the most important thing, is what about quality of life, like changing diet, did it improve or worsen quality of life? And what we did see is that actually quality of life also improved for these patients over time. And this is the global health status, which is overall just general feeling of well-being. And then also shortness of breath and fatigue improved. We also surveyed patients and said, like, with this intervention, did you notice changes in any of these symptoms? And this was subjective, of course, but you can see the green lines showing you that a lot of different symptoms, patients had subjective benefits to them. Although this is a small study, but you can see GI symptoms, body weight, cholesterol, hypertension, diabetes, prediabetes, self-confidence, depression, anxiety, sleep, a lot of different things. And all patients said that they were able to actually follow the intervention and didn't find it too difficult, and they would also do it again if they had a choice. And about 4 patients actually were able to save money because they were able to stop medications like insulin or potassium supplements or something for antidepressant, for depression, things like that. So overall, the patients actually felt better. And then we also looked at other things that we know are associated with cancer progression. So insulin resistance, we looked at insulin levels. Those improved. Also, adiponectin leptin ratio, a higher ratio is better, and that improved too. And also the microbiome. And if you heard about the microbiome and diversity is one of the things where more diversity is generally associated with better progression-free and overall survival in many different studies for cancer. And we were able to see an improvement in diversity, and this diversity sustained even to 1 year out. And similarly, other healthy bacteria also improved. When we looked at inflammation, we did see a reduction in inflammation, and we saw a change in inflammation subsets too, such as classical monocytes improved and non-classical monocytes, or the inflammatory cells, reduced. We saw similar findings with inflammation changes in the patients that lost weight. You can see in the blue side are mainly the patients that lost weight compared to the orange where they had less weight loss. And we looked also at the bone marrow cells. So when we looked at the blood, I told you we see the changes in the monocytes, but we also looked at the immune cells in the bone marrow, and we see very consistent findings from the blood and the bone marrow, suggesting again that these changes were even 1 year out sustained. So there were 2 patients on the study who had rising M spikes for the last 5-6 years before going on the study. And the blue lines show you their M spikes before they went on the study. And the red line shows the change in the trajectory of the disease when after they went on the study, suggesting it slowed down potentially their disease progression. So we have now the Nutrivention 3 trial enrolling. If any patient's interested, we're happy to have you on the study if you have MGUS or smoldering myeloma and meet the eligibility criteria. The patient can be anywhere in the country, but they have to be willing to come to the New York or maybe Atlanta when it opens there, about 6 times spread over a year. We don't cover the cost of travel, but we do cover the cost of the intervention. So as long as the patient's willing to travel, we would be happy to have you. We've had patients from other states come and join the study. We're also looking at supplements here to see if supplements have any additive benefit to diet or even separate benefits. We have another study that's a decentralized study that's going on with the Health Tree Foundation. And this study, if you have smoldering myeloma and anywhere in the country, you can take part. You can enroll through the Health Tree Foundation portal, and we will ship you the intervention and you would ship us back the specimens. This is one patient on the study who before the study, and this is with patient permission, but before the study, this is how he felt. And then this is after the study. He's now 3 years out of the study and still feels overall very good. And that he was on insulin for 30 years before going on the study and was able to stop that as well with being on the study. So, and then the last thing I just want to talk about is another study we had done in the survivorship space. So when we think about after patients have had chemotherapy and now they are on maintenance therapy with lenalidomide, does diet and microbiome affect outcomes such as sustained MRD negativity? And we had done this with Dr. Lisokin and Dr. McLachlan and Dr. Durkat. And what you can see is that patients that had better microbiome diversity, again, the variety of bacteria that we showed we improved with our interventional study, and better, healthier bacteria and also butyrate levels were associated with more likely to be sustained MRD negative or incomplete remission. And this was also associated with the dietary changes, like flavonoids are plant chemicals, and healthier proteins like plant and seafood proteins, suggesting that diet may affect the microbiome and through that affect potentially myeloma control through effects on the immune system. And so we are looking at this in a study on maintenance therapy where a subgroup are getting the dietary intervention, and this is currently enrolling too. This study unfortunately requires patients to be at MSK for treatment or be able to at least come in once a month for treatment to be on the study, and it's after their induction therapy. So with that, I'd just like to conclude, I think that, dietary changes can make a difference for quality of life and potentially even anti-tumor response, but that is something that needs to be studied better and understood. We just see early signs for some patients, but that's what we're trying to study better with all of this. And this is a review article that we had published in Leukemia around all of the data that's available for diet. So if you wanted to read more, that's something you could look into. And just some tips when we think about all of this is how do we apply it if we're not part of the study, is trying to focus on whole grains and unrefined grains and reducing the refined carbohydrates, improving fiber intake to over 30 grams if possible, with a diversity of plant foods and prioritizing plant over animal sources of protein if possible, and reducing saturated fat and improving unsaturated fats. And this is the healthy food plate where about half the plate is fruits or vegetables, a quarter is whole grains, and a quarter is protein, but mostly plant sources of protein. And so I think with that, thinking about it more as a lifestyle change and not a diet, and making small swaps over time gradually can overall then make it more sustainable than trying to do everything together. And when we talk about a healthy diet, it doesn't have to be just raw salads. It can be everything you like to eat, but if you like eating a burger, maybe you swap out a hamburger for a black bean burger, or if you like eating a curry, then you think about instead of chicken, maybe tofu. So this is just small ways in which you can increase the plant foods that you're consuming on a daily basis, which over a long time could be helpful and beneficial. So with that, I'll just like to thank my team, the patients, collaborators, mentors, and funders for this work.
Thank you. Yeah, that's fantastic, and that's exciting. And there's a lot of opportunities for getting a patient's sort of a soft way into making some changes that have some. I mean, you've have some notable outcomes, really in a short period of time. When did you start doing these studies?
I started in 2019, the idea started, and then actually this pilot study opened in 2021. So not too long, but yes, it's been now since 4 years or so working in
I mean,
this.
that's a pretty dramatic and response. I mean, the outcomes are pretty obvious from early on. It seems like, and so it seems like, and it seems like to me, anyways, that you're focusing on the right things in what's sustainable for the patient. If it's something they feel like they can do, and taking those sort of post-study surveys to determine what it is that they're capable of doing and how they can change, it shows that this is something not only that's sustainable, but it's almost immediately beneficial.
Yes.
So that's really awesome. Thank you for that. And we'll come back to that and after we get to the end and have some conversation about that. So, Dr. O'Donnell, I'd like to jump in and talk about exercise as a therapeutic tool. So you've made exercise and physical activity a priority in your personal life as well as your professional life. You and I've talked about that before. So could you share some insight on what you've found in prevention, treatment, and quality of life?
Sure, I'd love to. So let me pull up my slides and I'll get going here. Let me see when it's in full screen mode here. All right, are you seeing the big screen? Good. So thank you so much for welcoming me to come and talk to you today about a personal passion of mine, which is exercise. And I have been fortunate within my career to be able to incorporate some of the elements of something that I'm personally very passionate about. So I think this started back when I was a fellow. I noticed very often patients were asking about what they could do to help themselves. And so, Urvi just talked so beautifully about some nutritional considerations. Exercise is always a key one, but there are other dimensions of this too. And they're really, I think, neglected as part of our visits. And it's hard, particularly if you're practicing myeloma. There's a lot of other things to talk about. And so for me, my background is in athletics. I grew up playing sports. I played 2 D1 sports through college, and then I tried to be a professional athlete for several years after college. And, to this day, including today, I bike to work 40 miles round trip, 9 months of the year. And today it's gorgeous in Boston. We've got the marathon going on, so I couldn't be happier to be able to be out there. But I think part of why I do it is because it makes me happy for one thing, but I also, have been fortunate to be trained, professionally and just, what good nutrition looks like, what good exercise habits look like. And so the more questions I got, the more interested I became in thinking about how we could integrate discussions of lifestyle into our practice of medicine. And so what it turns out is there's actually a field called lifestyle medicine. And lifestyle medicine is the evidence-based integration of diet, exercise, managing stress, relationships, sleep, and the avoidance of risky substances into healthcare. And so this is a board certification specialty that I've studied in, and I started a clinic apart from my myeloma clinic so that we could talk about these considerations and give patients the time and space to talk about the lifestyle considerations that are most important to them. And so why do we care about, our lifestyle? How does it impact our lives? I think everybody tuning into this call recognizes that their lifestyle affects their quality of life, can potentially affect side effects of treatment, our ability to function, to live our daily life, mood, energy, and actually may impact cancer outcomes. And we just saw a nice example that Urvi showed where potentially change in diet may improve monoclonal protein levels. And so I'm going to focus on exercise today, but as I mentioned, there are really 6 pillars of lifestyle. So why exercise? Exercise has been demonstrated to improve quality of life. It is the only thing that has been consistently demonstrated to reduce cancer-related fatigue. So although it seems counterintuitive that exercising is going to make you less tired, it does. I think it's probably multifactorial, and part of it may also be improving sleep quality, where you move enough that you're actually tired, and sleep well can also improve anxiety, libido, and social functioning. And so there have been a lot of different studies, not too many within the myeloma space, and I'll get into that, that look at physical activity. And so this is a demonstration of a big meta-analysis of data of exercise. And what we see is, just as I mentioned, significant improvements in patient-reported outcomes, such as quality of life, fatigue, and anxiety, but also improvement in body mass index, body composition, fitness, and strength. And exercise is safe. And so I really want to, if there's one point I emphasize today, it does matter where in your myeloma journey in particular you think about it, but exercise has been studied in myeloma and done under the right conditions and making sure you're clear by your doctor, which I'll get into in a bit. Exercise can be done during treatment for cancer. So what are the recommended guidelines, the historic ones, and where are we now? So the kind of American College of Sports Medicine and the American Cancer Society reflects their guidelines, recommend for 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise per week with resistance training 2 days per week, which consists of 8 to 10 exercises for 10 to 15 reps. These guidelines were then revisited and revised and said that patients can get benefit if they exercise 3 times per week, at least 30 minutes. And so anything you do is better than nothing. And so what I hope we'll really get at is what is doable. But I just want the take home from these guidelines to be, there are targets. So we're thinking, anywhere from 30 minutes, 3 days a week, up to 5 days per week, trying to integrate strength, which can be challenging for myeloma patients. And I will get to that. But having a number in mind sometimes helps, particularly if you're goal setting. And so what is moderate intensity? So light intensity is no noticeable change in your breathing pattern, whereas moderate would be that you could talk but not sing. Vigorous exercise would be saying a few words without having to stop to catch your breath. And so when you think about embarking on exercise or the types of activities that you might pursue, choose something you enjoy. And kind of like Urvi just said when she was talking about diet, trying to do everything too much all at once can overwhelm people. Same thing with exercise. It doesn't need to be 30 minutes immediately. It can be 10 minutes. It could be 15 minutes 3 days later. It can be 15 minutes for 3 weeks and then bumping it up to 20. You have to adjust to where you are. And you also have to set feasible goals so that you're inclined to do it. So choosing activities you want and for durations that will start the process of engaging in activity. Try to do it every other day. So if you're setting a new behavior goal, try to make it at least every other day. And try to find things that potentially, like classes where you may engage with other people, so that it's stimulating. Support is critical, and I am going to talk about myeloma specific support, but engaging a fitness expert, setting goals both short and long term, and where you are in your treatment may dictate your goals. If you're looking towards a transplant, for example, or CAR T-cell therapy, you may have very specific short-term goals, which may be just to get up and ambulate several times a day during a hospitalization, versus a long-term goal, which is say, I'm going to get back to walking 3 miles every day. So those are some examples of short-term versus long-term goals. Find a friend, find a partner, find your community, whether it be within myeloma or within your local community, and use your devices. They are replete with options for energy and information feedback. So use those to your advantage. And if nothing else, try to avoid inactivity. Particularly at the start of any cancer journey, you'll see that most people are jumping in, trying to offer to do and help in so many different ways, which is great. But try to keep to your normal activity. Try to do your daily activities. So, whether that is just emptying the dishwasher, putting the laundry in, don't become inactive. And if you are inactive, be conscious of the times where you're sitting or sedentary that you might be able to change that. For example, if you're talking on the phone, rather than sitting in a chair to do so, stand up, walk around your house, put your headphones in and try to move. These are things that it does not need to be the Boston Marathon. It can be as simple as just standing up and moving around when you're on the phone. And that will ultimately help you and will minimize the amount of deconditioning that can transpire during a cancer journey. One of the things that can be very helpful. So myeloma is a unique disease where up to 80% of patients may experience bone lesions. And why do we worry about those lesions? Well, one, they can be painful, so they may restrict your ability to exercise. Two, they could compromise the integrity or the strength of the bone. So you need to make sure that it's safe for you to exercise, particularly when it comes to lifting weights. And I know that Dr. Hillengass Jens is going to talk a little bit more about some of the bones and other dimensions of this. But these are conversations that need to be had with your provider to make sure you are in a position with your multiple myeloma that you are able to engage in exercise. Now, different hospitals have different amenities, and you'll never know what they have unless you ask. So many hospitals have cancer rehabilitation specialists. We had a set apart program, which was great, someone who was trained in physical medicine and rehabilitation, but physical therapists can play this role as well. And so making sure that you ask your physician if your team or if your hospital has something like cancer rehabilitation available. And then if not, could they refer you to physical therapy? I think that physical therapy is a highly underutilized way of preserving fitness, particularly in the myeloma community. So you can be referred to a physical therapist, and that will be covered by most insurances for things like cancer deconditioning. And so you don't need to have a torn ACL to see a physical therapist. They can be highly beneficial for creating individualized programs that are covered by insurance. So one of the things we worry about when people are on steroids, such as dexamethasone for a long time, is loss of lean muscle mass. So working with a physical therapist or a trainer to work on core stability muscles that will help not only prevent loss of good muscle, but also fortify those, putting patients at less of a risk of fall. So physical therapists can also help work around specific pains or injuries like compression fractures. A lot of my patients, I referred them to physical therapy after they'd had a kyphoplasty, because sometimes there can be painful muscle spasm around that. So again, it's really knowing what resources there are. I think physical therapy is a tremendous resource for patients. And I encourage you, if you're thinking about exercise and you've not yet done it for a while, or maybe you've gotten away from it, this is a really safe, good starting place for a myeloma patient. And so you need to begin by talking to your physician. And so you have a team. It doesn't need to be the doctor. It could be your, NP, PA, someone on the team, and saying, I'm interested in exercising. Let them help you determine, are your bones in a safe place for this? And if so, how can they get you to the right resources you might need, such as a physical therapist, with an eye on really getting you to where you want to be, lifestyle wise and ability wise within your own life. There are specific questions that everybody should ask independent of your bones. And so, this is the physical activity readiness questionnaire. And so these are things like if you're having chest pain when you exert yourself, if you're feeling dizzy, these are warning signs that you really need to talk to your doctor before you start to exercise. But in the absence of these symptoms and with appropriate clearance, exercise can be a really important part of helping you maintain your own physical well-being and improving your potential mood and outcomes. And so this is a picture. This is the MMRF hiking team from the 2008 Kilimanjaro ascent. Kenny, I saw that you guys are going to be doing an ascent of Kilimanjaro this fall. Six of the
Absolutely.
people in this photo are cancer patients on myeloma therapies who made it to Kilimanjaro. So anything is possible, and this was an incredible experience. I feel like it was one of the best gifts I've ever had as a provider, to be able to walk alongside patients, loved ones of patients, and sharing that experience. So like I said, 6 of the people in that picture are myeloma patients getting up Mount Kilimanjaro. And so, with this in mind, that's me on top of Kilimanjaro, looking out over a nearby mountain. But all of these are pictures that I've taken from my bicycle. The one of me riding up Mount Washington is my husband taking of me. But the point is, there is a whole world out there that can raise your spirits, that can enrich your life. And so it doesn't need to be biking up a mountain. It doesn't need to be hiking up a mountain, but talking to your team, setting goals. If it's just, some part of every day being out there and engaging in life, it's doable. And, hope that this talk inspired you to think about the ways in which you can either connect with or reconnect with physical activity if you're not doing so currently. So thank you so much.
And well, thank you. And I think that you said the things that are at the top of a lot of our minds in and how do you start? And I think that's one of the biggest concerns and one of the biggest maybe overwhelm points. There's not much about cancer diagnosis that doesn't involve some sort of anxiety anyways. So jumping into something that might be a little bit unfamiliar or maybe a little scary, it's sort of, well, I need to do 30 minutes for how many times per week, et cetera, et cetera, et cetera.
Right.
And so by addressing that right from the beginning, I think that it doesn't need to be 30 minutes.
No.
And I have this conversation with those that are athletes that I coach, even if it's just it's on their plan, and what I call just tying your shoes or putting your shoes on. So sometimes if you make that the minimum, the low bar that you hit, then you've actually accomplished something at that point. And so starting there, and I think that's what I heard that you were saying, that sometimes it's that 10 minutes.
Yep. And that's the thing, especially it's just getting going. You know, you can set a long-term goal of hitting a 30-minute mark, but 10 minutes is a great starting place. 10 minutes every other day. And like some practical things, like, so maybe you're not there, maybe you don't have time. We hear people say, I don't have time. So small things like taking the stairs at work, or instead of going to the bathroom, you know, at the nearby one, going to one further down the hall, just getting some extra steps and going upstairs, going downstairs to go to the bathroom, parking one stop further away, parking at the far corner of a parking lot, just to like, these are small little things. Or frankly, even just dancing around your house, like putting
And
on
they all
some
count.
music. Yeah, just put on some music, purposeful
Yeah.
movement.
Yeah, they
It
count, and
is,
they all count. It's sort of like from the running perspective. I've certainly heard plenty of people who say, "I'm not a runner, but I just went out and did a 5 mile hike, or I just spent an hour and a half moving on my feet." You're a runner now. You just did it really slow. It may have been 18-minute miles, but you did it, and so so you moved, and that was the point, is that you stepped it up to the next level. How you define yourself is something entirely different. But moving and getting that sort of low level of accomplishment, just starting somewhere. And I love how you introduced the idea of physical therapist, using physical therapy as a safe tool in order to get started. Something again that's scary. It's a great opportunity. I can speak personally. I think I get 32 physical therapy sessions per year that's included in my insurance, and I can appoint. I can sort of go ahead and assign myself to the appointment to go to the physical therapist in order to do those things, to strengthen things that are weak on me, or make sure that I'm again not getting injured, and that's part of the big thing, because that's going to slow you down too. So you jump into something that's unfamiliar and you're sort of full on, then that's not the place to sort of try to, well, run the marathon.
completely agree.
Yeah, absolutely. Well, so the next topic, we had set up our outline to talk about stress reduction and psychological well-being, but if it's okay with Dr. Hillengass, thank you for joining us. I'd like to go ahead and jump to you and have a conversation about integrating non-chemotherapeutic interventions and treatment plans. And I know that you had mentioned to me earlier that you have a study that's currently ongoing and you don't have your outcomes available yet, but I think it's a great opportunity to have a conversation about that. You've been doing this for a while now, and I think this is a really good time to stop and say, "Hey, how's that going?"
Yeah, thank you so much for having me. And it's always great to have Urvi and Betsy also on the call, because we are all similarly passionate about what we are talking about here. And I do have a few slides, but I think it might actually be okay to just talk about it. We did a pilot study where we basically try to address some of the things that were already talked about. I don't want to repeat too much. One of the focuses that I am very interested in is bone disease as well. And as you know, if you don't use it, we lose it. And there is known from, for example, astronauts. I always show a picture of astronauts working out, because they come back. I mean, they're in the peak shape. They're in the best shape ever. And then they come back and are basically disabled, right? So if we don't use our bones, our muscles, then we lose them. And they don't use them because they're in zero gravity. Sorry. And what we thought about is, can we do something safe? And Betsy already mentioned that it is the literature so far shows that there have not been a lot of complications if patients with myeloma enrolled in a clinical trial with exercise. What I cannot stress enough, and echoing what Betsy said, is that you should talk with your provider first. We have excluded patients from our trials before they were enrolled because we said, okay, this is just currently at this point in time, they're not eligible. They should not lift weights. I do have contact with colleagues from Australia who are doing a lot in osteoporosis with exercise, and they actually do heavy loading. They lift heavy weights, these patients, and they have done that also very successfully with not a lot of complications. So that encouraged us to do a pilot study, was funded by our local philanthropy in our institution. And we had 24 patients, and we offered them an in-person exercise training in our physical therapy department, which I can also just echo and say this is a great way to start. And they came for two exercise sessions, 1 hour each for 6 months. And then we evaluated things like functional status, and we measured that by the so-called 30-second sit-to-stand, like how often can someone get up from a chair without hands within 30 seconds, the 6-minute walk test, how far can someone walk in 6 minutes, and a lot of other these functional tests. And we found that almost all patients really benefited from that. These tests were better after than before the intervention. Unfortunately, COVID hit, so we could not really enroll as many patients as we wanted to. But we also saw, and what I think has maybe not been mentioned yet, and it came a little bit later, I apologize, was that we found even changes in the immune system. And as a lot of you know, that we need the immune system, a healthy part of the immune system, to fight the cancer. We use so-called CAR T cells, bispecific antibodies, and all these things. And even beyond the IMiDs, lenalidomide, pomalidomide, they use our immune system or the patient's immune system to fight the cancer. And to improve this immune system with a non-medical intervention is definitely something that we aim for. And we have shown that exercise can do that to a certain degree. We have seen that the exhaustion of T cells, and that's something that we see especially in cancer patients, the T cells that are part of our healthy immune system, they are exhausted. They show markers on their surface telling the person who is investigating it that these cells are not able to function as well as they would without the interventions, without chemotherapy, high-dose chemotherapy, without the myeloma itself. All these things, all these factors lower the function of immune cells. And those T cells are so-called exhausted. And we found that after the 6 months intervention, that the exhaustion markers were lower. So more cells had no exhaustion markers on their surface as compared to before. And that's something that was very encouraging to us. And as you mentioned, we do have now a larger study where we enroll 100 patients in an exercise arm, 25 patients with another cancer called myelodysplastic syndrome, because we want to see, okay, is this specific to myeloma? Is it better with others? And actually, a colleague asked us if she could enroll her patients in the study as well. So now we enroll MDS as well. And 25 patients do an intermittent fasting. And we don't have any data on that yet, but we have found that our patients really appreciate having this option to enroll in these things. And it has already been said, and it's exactly my experience since I practice medicine, especially cancer treatment. Patients ask, what can I do, right? We throw all our drugs at them. We throw high-dose chemotherapy, stem cell transplant at them. And they say, what can I do, right? Not being passive and being part of the intervention to improve their life is definitely something people want to do. And so we decided exercise and fasting are our approaches. There's some data that intermittent fasting can also improve the immune system, can have beneficial effects on cancer. Initially, when my patients asked me about fasting, I said, well, that's nice, and you might lose some weight, but it doesn't work. And then I went into the literature, and there's actually data in the literature, and I'm not sure, Urvi, if you mentioned that already, that healthy cells can recover or kind of go into this mode of fasting and just downregulate their energy consumption, while cancer cells oftentimes cannot do that. It's not much data out there for myeloma, but for other cancers, we know that fasting kind of starves the cancer cells to a certain degree. It's of course a very optimistic picture that I'm painting here, but there's something to be said about that, and we are measuring bone strength, we are measuring immune cells, and we are measuring body composition before and after these interventions. And I think those are the studies that we're doing right now. Unfortunately, we cannot enroll a patient who is not part of our institution, who has not presented here, because we need certain examinations that are covered by the insurance, like the monoclonal protein and all that. We could not afford to do that on the trial budget, but certain things we can do, and we can offer patients to become, for a certain time, patients in our center if the insurance covers that, and then we can enroll them in the trial. I have a lot of requests from outside, and unfortunately sometimes the insurance doesn't allow a patient to come here. And as you know, it's very expensive to be treated for myeloma, so we are very careful in advertising that. But if a patient lives close by area, Buffalo, Niagara, or if they find a way to get the insurance to pay for it, we are more than happy to enroll patients. And we have had patients from other states as well.
So is it pretty early in the process, sort of jumping back to, you talked about intermittent fasting. So
Yeah.
is it pretty early in that sort of where we are in studying the effects of intermittent fasting on those things? Is it still sort of, would you say it's still early in discovering the actual outcomes from that?
I think at the moment it is, because it's also a very wide field. There are different ways how you can fast intermittently. What we chose is a 16-hour fast and an 8-hour time of eating. And we obviously encourage our patients to eat as Dr. Shah would recommend, but they are basically allowed to eat whatever they want in that time, which helps with advertising for the trial, because people, when I tell them fasting, they're sometimes a little bit startled and say, well, that's not what I'm going for here. But
Sure.
a lot of patients really are interested, and we have restricted it to 1 month. And this is again a pilot phase where we want to see what signal do we see. Is it worth doing a larger study? Is it also worth randomizing to other interventions to see, okay, what are the different impacts of different interventions? And I'm sure, Urvi, if you have other experience and other knowledge about intermittent fasting, but I think it is still fairly early because there are so many different ways how you can fast.
I've seen Dr. Shah. Of course, when she was talking, she's more specific, of course, as to what the diet is with the intermittent fasting. At least what I've seen from my layperson's perspective of how people are using intermittent fasting, it was eating generally healthy or eating generally clean for a certain period of time, and then of course not taking in calories at all in general during that off period. So is there a focus when researching this or studying this on what the actual intake, what the calories are that are consumed, simple sugars versus something else, balance of carbohydrates versus proteins, any of that? Or is it
Our
just a sort of a
study,
more broad?
yeah, in our study, we have a diary where patients write down what they eat. We have not any prescriptions for that yet, so we don't tell the patients what they have to eat. But of course, hearing Dr. Shah's talks more and more, I do think we should do that in the time when patients are eating. Since this is very early in our area, at least, we have not done so yet. But Urvi would be interested in your thoughts as well.
I think in general, I pretty much agree with everything you said, and that intermittent fasting is a good way for also people to eat within the normal circadian rhythm or time window, where just now we have access to food all the time. So many times we're snacking throughout the day and late at night, early in the morning. And when you do something like intermittent fasting, you're actually doing what is normal or physiologic by now eating within a time window of what would be normally expected during the daytime and not during the time when you would be sleeping or things. So it helps the circadian rhythm of our eating pattern. And then also, because you're eating in a shorter time window, usually people end up eating less calories. But if they are going to just eat more during that time when they're not eating less often, then often that may take away the full benefit if they're eating the same amount just in a smaller time window. And what we have seen with the high fiber plant-based diets is because they are high fiber, even though patients are eating to satiety and no calorie restriction on our study, there is some calorie restriction that happens automatically because high fiber is satiating. And so even though they're eating more in terms of quantity. The calorie density of the foods are less, and so they're eating less calories in general. And so there is some calorie restriction that happens with improving diet quality, like we have seen. And so it's just different ways in which we're kind of maybe restricting calories. But when you improve diet quality, you automatically often end up eating less calories too.
And I'm curious as to how that. I'm thinking about fueling for performance. So sort of like for an athlete who's actually having to consider what it is that they're taking in their body if they're trying to increase strength or decrease weight. So all of those things are factors. I wonder how much are we to the point yet, at least in this type of research, to where we can start seeing that we can start fueling for or encouraging fueling for performance, if you will. We're not for doing some sort of athletic event necessarily, but for just life and quality of life issues. Dr. O'Donnell, has some of that come up in the conversations you have on quality as well as how you fuel?
Yeah, so not as much. A lot of, interestingly, through lifestyle, where I did see a lot of breast cancer patients, a lot of people talked about weight loss more than anything, and also just body composition. And so I think that one of the things we're trying to study and learn more about is the microbiome. And so, relevant to a cancer patient is this question of how are we best fueling ourselves? And so I just want to echo what Urvi said, just about trying to have a diverse diet, and really create gut diversity with the bacteria that are there. I think that will lead to generally better health. For patients who are on steroids, dexamethasone does increase blood sugar levels. So being conscious of our blood sugar levels to some extent, I think is useful. But really, I think there's not a lot of great data for what the best diet is for cancer, and exercise depends on the types of exercises you're doing. So I think the simple message that I hope people take home from today is really trying to incorporate fruits, vegetables, fiber into your diet, and think of it as striving for a diverse gut microbiome.
No, that makes a lot of sense. And maybe that's an opportunity going forward, something for the future
Yep.
to, as we dial this in, is to make it more specific and focus on the areas that again that are either lacking or need some concentration, coming from the diet nutrition side. So that makes a whole lot of sense. And then again, all of this is that holistic treatment of each individual patient. All the stuff that we're talking about, the purposeful movement, the diet nutrition. But I think there's another component, which was a giant one. I don't know anybody within the cancer space that doesn't have to deal with anxiety and or depression after a diagnosis. It's tough. This is hard. This is new. We're moving into a space that requires a lot of focused energy that's not on all the stuff in life that we'd rather be doing. So I'd like to talk about, and this is more of an open conversation because this isn't individually what y'all are presenting, but more of a roundtable discussion and the importance of mental health and stress reduction techniques, things that that you've seen from from where the three of you sit and where you've been, and how that overall affects. I mean, and also keep in mind the standards that were adopted last summer from ASCO for mental health assessment, mental wellness. What are some of the things that need to be observed? What are the things that need to be paid attention to? And how is it that we can actually increase our mental wellness, overall mental wellness, and feel better?
I'd be happy to talk about this. So,
Sure.
this is a topic that was particularly interesting to me, not just of patients, but also of their caregivers. So I wrote two different papers in this space looking at patients and their caregivers and the amount of psychological distress. So that includes clinically significant depression, anxiety, PTSD. And I did this over kind of the trajectory of myeloma therapy. So we looked at 180 patients, 60 with newly diagnosed disease, 60 who are on second or third line therapy, and then the people who are on 4+ lines of therapy. And what was really interesting to me is that the distress that patients experienced was pretty uniform across the board. So it's not like it got worse over time or it got better over time. It started high and it stayed there. And what was interesting is that we paired people with their caregivers, the level of anxiety was actually higher in the caregivers. And so it's not just about the patients themselves. I think it's about the whole environment that people are in. And it is distressing and it's long sometimes, it's hard. And so we were capturing people when they were on active therapy. So it may not reflect what life is like when you're on maintenance, which may be better. But I think we really do have to be dialed into this. And so, the estimates that we saw, was about a quarter of patients had depression going through myeloma therapy. And that's not unexpected. And so I think it's so important to verbalize when you're having these issues because, sometimes we talk about your physical symptoms and we don't ask enough doctors, providers about the emotional symptoms. And particularly when you throw steroids into the mix, which do a variety of different things. They can be mood altering. And also they can be sleep altering. And so, whether you get both of those symptoms together or independently, it's going to affect your mood. And so making sure, like, what are the things that your team can do if you're experiencing depression, anxiety? So, there can be medications, there can be counseling, there can be resources. They can recommend exercise. But then what if you're not sleeping? And what if you're not sleeping and not telling people because you're taking your dexamethasone, you're taking 20 or 40 milligrams and you're 4 months into therapy? You don't need to be doing that necessarily. And so making sure that you're letting your providers know the types of symptoms you're having so they can potentially modify them, which may impact your quality of life and your mood. So these are really important, and the limited data is very understudied in patients in myeloma, but definitely support the fact that there is a good amount of anxiety, depression, and PTSD within patients. And really, it needs to be a conversation so that the right resources can be identified. And we need to develop better tools for helping our patients.
And that negative impact of things like dexamethasone it's a vicious cycle.
Yeah.
When putting you into those negative sleep patterns, which again exacerbates those feelings of distress and depression and anxiety. And honestly, I would have thought you said a quarter were experiencing depression. I would have guessed more, but maybe that's just how it's being reported or at least being analyzed.
So clinically significant, meaning like not just
Okay,
a
fair
low
enough.
mood, but where it would meet criteria for clinical depression.
Understood. But so right, so it's either way. Everybody's experiencing something, and again, it's tough to break out of. I would assume. Also, once you're actually in there and you're in the treatment process, so again, treating the whole patient and caregiver is important, and that's another thing I hadn't thought about. You said that the anxiety level of the caregiver was significantly higher.
Yeah.
And I would imagine that's not helpful.
Right.
That's not helpful. So how do you address that at the same time? Do you address that first? Are they part of the patient team that you focus on trying to correct?
It's a hard question, and Urvi and Jens jump in. When I was a fellow, one of my colleagues drew the concentric circles of patient care, where the patient's at the center, and the primary caregiver is the next circle out, and so on. But you're not allowed to complain inward. You can only complain to the next circle out. And so I think it's hard because you have a patient who's going through so much, and you have potentially a caregiver that's also experiencing, but you don't want either person, you don't want the caregiver, transmitting some of their anxiety onto the patient, but it's hard when you're in tight quarters. And when the duration of therapy is so long. And so, having relationships, so supportive relationships is so critical to the cancer, to life, but to the cancer experience in general, so that you have outlets to help mitigate some of the emotional challenges that you go through.
Yeah, I mean, where do you start, right?
Right.
Dr. Shah, you were gonna say something.
No, I agree with all of that. I was just gonna add that sometimes with myeloma, given it's such a marathon of like treatment periods and intervals, that often when a patient finishes induction therapy and is going on maintenance, I make it a point to actually tell the patient, now it's the time to focus on everything in your life outside of myeloma. And the maintenance, you just come and see us every 3 months as you're on it. And now what are the things that you've been wanting to do, or like hobbies, or even like we talked about all these lifestyle things, whether it's physical activity, nutrition, other things. But that is the time where you want to focus and increase those things to help cope with the rest of it. Because if we stay in the mindset of being a patient all the time, then it's very hard to come out of that and constantly worry about like, what about the next labs, or when do I have to come in? But it's important that once we get to that maintenance phase, or even once we're in stable periods in our disease, that we're now focusing on other things outside of the myeloma. I know it's easier said than done, but I think that my own experience going through cancer as well, like I think what helped me cope is having things that I was working on outside of focusing on the treatment, and that passion or interest outside helped make it easier to go through the treatment. And I think many times we don't do that because we're so busy in the treatment that we don't have time for anything else. But I think that that's very important.
Absolutely. And I think that that's another way of, again, just focusing on the person, just being, as opposed to focusing on the individual component that doesn't really necessarily define who we are.
Yeah.
And that's cancer.
And if we're so focused on the disease, then we are not really living. And what's the point of the treatments extending our life if we're not able to enjoy that life that we are extending it with? And so I think that that's another reason why I think that, yes, we want to live longer, but what's the point of living longer if we're not living better and enjoying that time that we get? And so I think that's very important as a patient, to reframe the mindset or shift the mind towards focusing on things that are within our control and things that we really want to do in life, that there's never a better time, or there's never going to be a perfect time to do it.
I think that that's the brilliant part of what the three of you are focused on, is living with cancer as opposed to running from it, or constantly fighting it, the battle. And I know that we use a lot of that nomenclature about warriors and fighting cancer and so forth, but sometimes that means living. And again, what's happened over the past really few years, couple of decades, but certainly the past 10 years, is how exponential the medical improvements have been, the treatment improvements have come in cancer, to where folks can live with cancer. It's so much of it has become more chronic in nature, and that it's something that it's a part of what we deal with on a day-to-day basis, but it doesn't necessarily have to define what our whole day is about. And so much of what you're focused on is how do we get back to that? And that's really living. So what it is that you're researching, what it is that you're encouraging patients to do, what it is you're giving them the resources and tools to do, is to live with cancer. And again, I think that so much of that mental health aspect, we all know it's there, it's back there, but sort of how do we deal with it? So what about some stress reduction options? What are some things that can be thrown in there? What are some stuff that we can do? I mean, and I would argue what you're already doing does that. So the focal areas that you're talking about today, that you presented on today, those are the things that you can do. So I guess maybe the question is really more immediacy, because there are certainly moments where we get wrapped up into the day or in the moment, and we're overwhelmed by that most recent lab result, or the most recent PET scan. We have a most recent bone challenge. What is it that we can do to immediately reduce stress and put ourselves in a space to where we can get back on track?
I think every patient needs to figure out what is right for them and what works as a stress reduction. And it's good initially to try multiple different methods. So yoga, breathing exercises, acupuncture, exercise, nutrition, or hobbies that they're interested in. There's the EFT technique as well in terms of handling stress, which is another method. There are a lot of different psychological methods that can be used, and I think meeting a therapist too. So trying these different things and then seeing what works for you versus not, but being open to trying the different methods.
Have you had any patients that have come to you that you've witnessed that have maybe a technique or some sort of anecdote that has worked for them that you've seen something specific?
I've had some people get a lot of success out of having, groups that they share their experience with. And there that can be a double-edged sword. It's very dependent. Sometimes people find that they can get more scared because they hear, you get the extremes of stories. But I think
Yeah.
having a shared experience and being able to talk things out, I've definitely had patients say that that's helpful, as part of their coping.
Yeah, I can echo that too. I have patients who say, leave me alone. I don't want to talk outside of my clinic appointment. I don't want to talk about my cancer. And others say it's so helpful to know I'm not alone. I'm not the only one going through this experience. And to be honest, oftentimes with the side effects of treatments and even symptoms, sometimes we doctors have kind of our standards and we do something. But I have learned a lot from my patients when it comes to neuropathy, for example, like what they do, what they come up with, and they help each other. And then one patient says, oh, this helped me. And another one says, oh, it helped me too. And then the third one can try that out. So I think this knowing from each other and knowing they're not alone is definitely helpful. And we see that in our exercise study as well. We were a little bit worried. Now we do it virtually because of distances and everything. But we have seen that patients still enjoy this, having other people doing the same thing and supporting each other, motivating each other, especially in the realm of exercise. I don't want to kind of drift away from that back, but I do think these social interactions can be very helpful, and it depends very much if you're more introvert, extrovert, and what your life otherwise looks like. And I absolutely I had to smile when I heard you telling that, Urvi, that you say them now is time to live. And that's exactly what I say to them too. And I've heard that from a lot of colleagues also. It is important that we give the life, not only more years in life, but also more life in the years.
That's a great point. Yeah, thank you. That's and I think that's an excellent way to put it. Life in the years. And I think that so you talked about the support group. We have a monthly support group, a Zoom support group with Throwing Bones, and we call it our Cancer Active support group because we want it to be more specific. We don't want it to be just a gripe session or an opportunity. And I'm not saying that maybe there's not a space for that, to have that opportunity for people to say how hard it is, to talk about how hard it is. But that's not what we're going to focus on. We're going to be more practical in nature. We're going to talk about things like we're talking about here today, the things that actually can focus on quality of life and living, and how lifestyle can influence whether you're living with cancer or whether it's beating you up and it's winning. And so I think that that's an opportunity to share again with patients and caregivers and healthcare providers even can have an opportunity to come in and you can talk about what you've seen. You're at the forefront. You get to you're the crux. You get to see where the patients and caregivers come and what are and hopefully they're sharing with you what's working and what's not working. And so I'm happy to hear more about those things which are working and things that are challenged for them, and how maybe one has overcome something that might be beneficial to somebody else. Um, I think I think that's the opportunity to where you're at, where the three of you are at. It's the time to talk about how to improve those things in a very real way. That's not just some sort of chemotherapeutic intervention, because I think that's while it's absolutely necessary and it's essential to get it to those chronic spaces. It's not the only one, and again, it's about living again. So thank you for doing that. I'd like to see if there's any other questions and open it up, of course, to the. I know we have people that have asked questions to the our panelists who have been answered. So thank you for panelists for answering those questions as they come up. I've gotten a few others, but if there's any others, let's see. We did have one. Dr. O'Donnell, I did see that there was one question that was true. It was regarding confirming about dexamethasone and muscle mass.
Mhm.
And the question was related to she's been on dexamethasone for 2 years, and her concerns are about weight gain, and dexamethasone rage. I'm not sure specifically what that's about, although I can say that I do refer to it as the asshole drug often.
Yeah.
Um, so I understand.
Yes, so I'm happy to comment on that. So as a class of drugs, we know that chronic steroid use is associated with gain of visceral, so, fat around your belly, loss of lean muscle mass. And so, it is the chronicity, meaning the long-term exposure that can contribute to that, can also thin your bones a little bit. And we heard Jens talk a little bit about that. And it's a necessary drug as part of a myeloma regimen and some of our more historic, or it's an often incorporated drug. But the dose, there's flexibility with that, and especially if you're having mood effects. So I always say it's like a third, a third, a third. A third of people don't even know they're on it. A third notice it somewhat, and then there are a third people who really can't tolerate well, and can be weepy, can be rageful, all of that. And so if you're experiencing that kind of symptom and you've been on it long enough to know that it's consistent, you can definitely back off the dose. You can cut it way back and maybe cut it out, depends on where you are in your therapy, but it may make you feel better. And osteoarthritis is challenging, that's an aging thing. And one thing that does come up, and I think this really ties in nicely with the theme of activity, is, if you need a knee replacement, it's okay to get one. We want you to go on living. And so, for patients who have severe symptoms of osteoarthritis that limit their ability to participate in the things they want to do, whether it be a knee or a hip, just because you have myeloma does not mean you cannot have hip replacements or knee replacements so that you can get back to doing what you want to do.
And just so you know, if anybody did want to share, if they had questions that they wanted to ask, there is a Q&A button on the bottom of your Zoom screen. If you would just click on that, and that's actually how you would ask questions. And I lost my screen. There we go. And this is the problem with clicking too many buttons when you've got too many on there. Well, I don't see any other major questions unless I'm missing anybody else.
I see a question from
Okay.
uh,
Oh, there we go.
asking about the study opening in Atlanta. That will be the study for MGUS and smoldering myeloma and not for maintenance therapy, unfortunately. So if you're on maintenance therapy, then we don't have a study that'll open there as of now.
And when is that supposed to be, Dr. Shah? The Atlanta?
The study is already open at MSK. It's going through the IRB process at Emory, and I'm hopeful in the next few months that it will, but it all depends on the paperwork at that institution.
Sure. Do you know who's directing it down there?
It's gonna likely be Dr. Nisha Joseph.
Yeah, cool. Excellent. I'm looking forward to having a conversation with them in August. So that should be a lot of fun.
Nice.
Yeah. Okay. Well, I got to tell you, thank you to all three of you for coming today. I think this is exactly what I had hoped it was be. This is something that didn't feel like it was a lecture class. It's something that felt like that everybody could feel like that they were a part of and learn from, and they can ask questions if they needed to, and hopefully it opens up a conversation for more later. You're still early on, the three of you, in this idea, this concept of purposeful movement, mindful integration of everything holistically, what needs to happen to treating the entire patient. And again, living, as you say, Dr. Shah, living with it, and not in living with cancer, right? And so, as opposed to letting it beat you, the quality of life is actually so important for being here. So longevity is not just the earmarker for success; it's quality. Thanks to everybody for showing up today, and I really appreciate you being here, and hopefully we can do this again soon. Dr. Shah is going to send some experts our way next month for our support group for diet and nutrition, and we'll have more conversation about that later. So again, thanks everyone. Look forward to the link that you'll be able to watch this again if you'd like to. And we'll talk soon.
Thank you.
Thank you.
Bye-bye.
Seth.
Thank you so much. Bye, everyone.
Bye-bye, everybody.